Hi everyone, my name is Larson and welcome to my TED Talk, where I looked at what can the neuroscience behind eye movement desensitization and reprocessing, or EMDR, teach us about trauma within the brain, and how can this help us invoke new processes to help those who have experienced trauma. I'd like to begin today by inviting you to think about a traumatic event in your lifetime. Think about the feelings that stand out to you about this event. It doesn't have to be anything serious, but something that stands out to you, and something that you know may stick with you for a very long time. This could range anywhere from a death of a loved one to a death of a pet, or a high school breakup to a divorce. It can even be as simple as an embarrassing moment that stands out to you. Don't think too much on the details. Think about the first thing that comes to you. Your traumatic event may be very different than from your neighbors, and it's important to not compare that event. It just has to be meaningful to you. Now think of why this traumatic event sticks out to you, and what you have done in your life to suppress the onset uncomfortable feelings that it brings to you. This could be anywhere from therapy, medication, counseling, or maybe even nothing, as you've just let time do the healing itself. According to the Sidron Institute, an estimated 70% of adults in the United States have experienced a traumatic event in their lifetime, and up to 20% of those people go on to develop post-traumatic stress disorder, or PTSD. In a large sense, an estimated 5% of Americans, more than 13 million people, have PTSD at any given time. Approximately 8% of adults, 1 of 13 people in this country, will develop PTSD in their lifetime. Today we will be discussing trauma and how the neuroscience behind trauma can invoke new processes to help those who have experienced trauma in their lifetime. Specifically, we are looking at an upcoming process named eye movement desensitization and reprocessing, or EMDR, can help those who have experienced trauma and go on to develop PTSD or other trauma-related issues. One of the most difficult aspects to grasp around this subject was the complexity of trauma and what that looks like within the brain. Something I've noticed throughout the time I spent researching trauma was how trauma in our society is looked upon, and that is by its external symptoms. While the symptoms of trauma are the face of it and what we most often see, trauma is so much more deeper than that, showing in brain scans like this one. So the first step in this process was to recognize how deeply entrenched trauma is physically within the brain and what this looks like. I came to settle on this topic because of how pressing I believe the issue of trauma is in the United States, but more importantly, shed light on the unknown benefits of EMDR. EMDR was brought to my attention last summer, and I had no idea what the therapy was, what it could do, and its benefits. I was also interested to highlight the benefits of EMDR over medication, as it is known that prescription addiction is one of the largest epidemics in the United States. According to the Center for Disease Control, prescription addiction kills more people in the United States than car accidents, and the United States is the world's biggest addict. Hearing this scared me, and it still scares me today. In addition, I knew that it is the simple act of educating the public about EMDR and other integrative therapies that could change the way the public thinks about trauma and how to help those who have experienced trauma. By now you're probably wondering, okay, what is it? What is EMDR? EMDR is a therapy done in a counselor's office that was developed by American psychologist Francine Shapiro. Built to emphasize the role of deplorable memories in most mental health disorders, particularly post-traumatic stress disorder. The discovery of EMDR begins with Shapiro, as she noticed the severity of disturbing thoughts lessen with certain eye movements. In order to undergo the process of EMDR, a therapist must pre-diagnose the patient. The patient does not have to have PTSD specifically, but must have undergone a traumatic event that usually affects their day-to-day lives. Then the therapy follows an 8-step protocol and usually involves 3 90-minute sessions in the therapist's office. This 8-step protocol involves 1. Client history, 2. Preparation, 3. Assessment, 4. Image, 5. Desensitization, 6. Body scan, 7. Closure, and last, reevaluation. I have a 2-minute animation video that sums up the process of EMDR pretty well for those of you who are still confused.
If you have experienced something horrible and have developed psychological symptoms such as flashbacks, fears, sadness, or sleep problems, you may well be helped by EMDR, a proven and effective therapy. Suppose you have been confronted with a violent crime, an accident, you have been bitten by a dog, or you have had to deal with sexual abuse or violence at home. Such a powerful experience is stored into your brain with a lot of emotions. Once such a memory is stored in your long-term memory, it can bother you for quite a long time. The disturbing memory keeps coming back unintentionally, for example with feelings of powerlessness or believing you are not worthwhile. EMDR therapy can help you get rid of these complaints and feelings. At first, an EMDR therapist will ask you to activate the memory of this disturbing experience from your long-term memory. The memory is now stored in your short-term memory, also called the working memory. Then the EMDR therapist will ask you to focus on this horrible event. From there, the therapist will move his fingers in front of your eyes rapidly back and forth and ask you to track his fingers as best and as fast as you can. By keeping a traumatic memory in your mind and tracking the fingers of the therapist at the same time, the working memory gets to process a lot of information at the same time. As it is so much information, the image becomes blurred and loses its emotional charge. When the emotional charge of an image lessens, it also becomes easier to think differently about the experience. You will notice this because you feel less powerless or you feel worthwhile again. The intrusions have gone and you feel less anxious. You feel less depressed, you sleep better, and because you have managed to leave the experience behind you, you start enjoying life and looking forward to the future.
In my own words, the therapist sits across the patient and reminds them of their traumatic experience. While reminding them, the patient is undergoing BLS, or bilateral stimulation. This could either be the simple movement of the finger across the left-right side of the patient, as it was shown in the video, or a tone that the patient is listening to that is alternating back and forth. The patient is asked to remember the fine details of that event and asked other questions surrounding that event. While doing this, the patient is accessing what is known as their working memory area of the brain. Through the use of BLS, the patient is reintegrating the negative thoughts and feelings that surround that event. By having a quick moving form of stimulation that the brain is also focusing on, the mind is focusing on receiving a lot of different information. This allows the harshness of that memory to be dialed down and blurred out. Ultimately, the patient's brain is creating new, more comfortable feelings surrounding that traumatic event after the full use of EMDR, and allowing that memory to become dimmer and less tragic for the patient. The ultimate goal of EMDR is to access the brain's working memory area into looking at that traumatic memory and the associated stimuli that are inadequately processed and stored in an isolated memory network. This reduces the long-lasting effects of distressing memories. The process is done by engaging the brain's natural adaptive information processing mechanisms, thereby relieving the pressing symptoms. Bilateral stimulation is one of the most important aspects of EMDR. Without BLS, the brain does not create new feelings surrounding that traumatic event. As stated before, BLS can be the therapist moving their finger across the eye line of the patient, an alternating tone, or an alternating tactile object. While undergoing BLS, the brain is able to activate areas such as the amygdala and the dorsolateral prefrontal cortex, where memories and emotions are stored. This activation, shown specifically within the amygdala here, is what lets the patient form newfound feelings of comfort around their traumatic memories. In the dorsolateral prefrontal cortex, while undergoing the process of EMDR, there is less activation, which shows that negative feelings surrounding that memory have been stabilized, shown here. Being able to create new memories surrounding a traumatic event, the patient can reintegrate themselves into a more normal, everyday life. Take Lisa here, who was bitten by a dog 6 months ago and had to go to the emergency room to receive stitches. This would encase negative thoughts and feelings around dogs. Today, after the use of EMDR, Lisa has reintegrated her thoughts and feelings surrounded by dogs, and is thinking, this particular dog in this moment is friendly, even though I was bitten by an unfriendly dog 6 months ago. Another example of the re-establishment surrounding a negative thought is shown by a study done by Dr. Andrea Bloomgarden and Rachel Calagro, who looked into a randomized experimental design comparing 43 women who received standard residential eating disorder treatment, SRT, to 43 women who received SRT and EMDR therapy on measures of negative body image. SRT plus EMDR reported less distress about negative body image memories and lower body dissatisfaction at post-treatment 3-month and 12-month follow-up, compared to solely SRT. The empirical evidence reported here suggests that EMDR may be used to treat specific aspects of negative body image in conjunction with SRT, but further research is necessary. In addition to assisting those with eating disorders by restoring more positive memories surrounding body image, EMDR has been proven to help those with obsessive-compulsive disorder, depression, and even psychosis. While there has been little research done around EMDR and those disorders, scientists are hopeful from the research that has been done and are beginning to produce studies to test the benefits, if benefits can be produced for patients outside of PTSD. Shown in the United Kingdom, where Sheffield EMDR Impressions Investigation, or the SEPI, said, there's also a single-case experimental design with replications in the UK, which aims to ascertain whether clients respond to EMDR not only with an improvement in depressive symptoms, but also in social functioning. The development of eye movement desensitization and reprocessing is amongst a group of therapies called collaborative therapies, in which embodied practices are recently arising. Collaborative therapies refer to a group of remedies that focus on the client's own ability to solve their own issues and problems, and has a baseline intention to loosen the grasp of externalized issues. EMDR identified within this group as it focuses on the client's own power to solve the issue. In turn, collaborative therapies alleviate the physical response of a trigger and aligns the logic of knowing that you're safe with the body's ability to feel physically safe as well. EMDR is one of the most popular choices of therapy within the group, along with collaborative-based therapy, or CBT. There have been many studies conducted to prove the efficacy of one therapy over the other. Namely, one from the Psychology of Medicine examined both psychotherapies and compared one to the other, with results declaring the superiority of one treatment over the other could not be demonstrated. Trauma-focused CBT and EMDR tend to be equally effective. Differences between the two forms of treatment are probably not of clinical significance. While the data indicate that moderator variables influence the treatment effectiveness, we argue that because of the small number of original studies, there is little benefit to be gained from closer examination of these variables. Further research is needed within the framework of randomized controlled trials. So, what can we do with this information? Well, it's pretty simple. Educate. As I touched on before, prescription addiction is one of the largest health issues in the United States today. And without educating the public, it will continue to be so. Without the education of the profound benefits behind EMDR, those who may benefit the most from EMDR may never actually be able to get to EMDR. EMDR could change the face of trauma and how we realize it today, and how doctors treat their patients with trauma. I'd like to remind you, 70% of Americans have suffered from a traumatic event in their lifetime, and it is estimated that 5% of Americans have PTSD at any given time. EMDR and other collaborative-based therapies can not only offer relief from their pressing symptoms, but also open up doors for a higher quality of life, a life of stability, ease, and a life without the chance of developing a prescription addiction issue. Now I'd like to invite you back to think of a simple idea with me. Think back to the traumatic event you have previously thought of, but something has changed. You are less afraid of that event, and that event is less of an issue for you. Think of the world around you where there is a new hope for therapy in helping those who have experienced traumatic events in their lifetime. A world where less addiction and abuse of medication is. A world where EMDR is known. Think of how simple the act of education has created a positive change to those who have experienced trauma. A world where there is little need for prescription medication. With EMDR and the upcoming foundings, that world is possible. Thank you for being here today, and I hope you can take the information that I've presented you and begin to be the change that I just described to you, the change we wish to see in the world. Thank you.
Thank you, Claire. We'll open it up for questions from our panel. Audience members, please feel free to raise your hand if you guys have questions about her research as well, and she will call on you.
Okay.
So this is pertaining to the picture you showed of a healthy brain versus a PTSD brain.
Mm-hmm.
The treatment that you were describing seems pretty simple, of like thinking about the time where you gained PTSD and then moving your fingers. And I was wondering if there are brain scans post that treatment. Like, does the brain start to show signs of being healthy again, or does the PTSD still sit around but in smaller amounts?
Yeah, so I think I showed an image earlier. During and after EMDR, there are certain areas in the brain, like in the amygdala and the dorsolateral prefrontal cortex, that are specifically being activated, which allows that patient to create more comfortable feelings. Like, that event will always be there with them. It can't just be like hypnotized out of your brain, or like you can't just forget about it. It'll always be there, but through the process of EMDR, it allows more comfortable feelings to be created and allows the patient to better live with that event. And yeah, there are images out there. I didn't include them here. They were in my thesis paper, but I showed one of them, and it was the certain specific activation of areas in the brain. Izzy?
Did you happen to look into like how effective EMDR is in treating like trauma and PTSD versus how effective like medications are that are in place now to treat trauma and PTSD?
I didn't look specifically at what medications look like within the brain, but I took how common medication is used to help those who have experienced traumatic events, but also the epidemic of prescription addiction in the United States today, and wanted to highlight how EMDR doesn't create addictions and addiction problems to people and could be of better use to people. If addiction runs in the family, or they just don't want to, have to rely on a medication, but I didn't look at how it looks like within the brain. Lori?
What are the limitations? I mean, this seems sort of amazing based on like what you've showed us. What are the limitations of this? Are there cases in which EMDR is less effective or not effective? Like, where does it stop sort of being this miraculous cure-all?
I think in the long run, it stops being, sort of like a great thing. Like, I think one of the studies I looked at 3-month and 12-month follow-up, and it was great for them. But after that, I think the uncomfortable feelings and uncomfortable memories surrounding a traumatic event could start to come back, and I think that's where limitations start to come back in the long run.
So is this a therapy that people have to sort of continue doing and maintaining then?
Yeah, I think that's a limitation as well. Celia?
So I'm kind of confused, and also like, what if this is so great, then like why is not everyone doing this? But is it like, what if you lost a loved one like a week later and you do EMDR? The feelings of sadness just go away.
No, I think yeah. I think it's up to the patient and their doctor when they would want to introduce EMDR as.
So is there a certain stage of like grief that you have to be in?
I don't
for it
think
to
there's
actually
certain.
work?
I think it's really up to the patient and their doctor, but I think like a week after losing someone, no, probably not. And I think there's like certain aspects and like details at which the doctor will be like, okay, this patient falls under like, I think I could start to, you know, integrate themselves into EMDR. And I think not a lot of people do it because, like I said, not a lot of people know about it, and we need to educate people about it. Because if something happens to you, the first thing you think of is, oh, like I can take medication, like there's depressive medication, all sorts of medication out there. And I don't think a lot of people are aware of EMDR. Kieran?
So if it is in fact something where you would return to the doctor multiple times, what is stopping me from like practicing this within my own home? Like it seems like something where I can get a friend who can just be like, hey, recall this, and then I'm gonna put my fingers in front of your face and you have to track my fingers. Like why?
Because there's like
who's
the,
stopping me from doing
in
that?
my presentation, there's a certain protocol, 8 steps, and the therapist has to be, what's the word? Yeah, certified. The therapist has to be certified, and like, if you had a friend do that to you, you probably wouldn't notice the results that you would want to notice, like the event becoming less.
Right, but if you like educate and then people know the 8 steps because they're out there on the internet and you have the ability to practice on yourself,
Then yeah, you
would
could
it still
practice.
work or?
I don't
no?
think it would.
Okay.
And yeah, they would recognize that as soon as they try. Sierra?
It seems like most of the examples you used are kind of on a smaller scale, like a dog bite, for example. So would this work for like war veterans who had 4 or more years of like constant trauma built up that had really, really severe PTSD?
Yeah, most definitely. And that's what most of the cases that I looked at, like for my thesis paper, that's what EMDR is actually used on, like war veterans and victims of sexual and domestic abuse. So it's usually used on those who have experienced extreme trauma in their lives, but now with upcoming findings, it's been shown to like help those outside of PTSD, like I mentioned earlier.
So can you explain to any greater depth kind of the cognitive function of this bilateral stimulation? Is that the right?
Yeah,
is that
yeah,
the right word?
BLS.
It sounds like distraction, essentially.
Yeah.
I mean, I don't understand why.
That's essentially what it is. During that time BLS is going on, the patient is reminded of their traumatic event and asked about the details of that event. And while they're trying to focus on a very quick form of BLS, the brain is trying to receive a lot of different information and thinking about a lot of different information. And while that's going on, the traumatic event is like less and less and less and less tragic for that patient, because the brain is focusing on receiving so much different information at one time.
And then you mentioned that the memory still is retained potentially indefinitely.
Mm-hmm.
So it's not a reorganization of that particular network inside your brain. It's a momentary distraction. Or
Yeah,
like-
it's a momentary distraction, but the effects of that stay with the patient, because that traumatic event, it can't be, it's always going to stay with that patient, but the uncomfortable feelings are dimmed after BLS.
I'm gonna have to cut off our questions because that's all the time we have. Thank you, Claire. If you